We all know that there is nothing more precious than our health. We know that we shall take care of ourselves, eat healthy food, avoid stress, do sports, spend as much time as possible in nature, surround ourselves with nice people, and check up our health, even if there is nothing particular that happens with us. But do we all do it? The doctors say clearly no, or at least most of us don't. So, prophylaxis is something that is supposed to be discussed as often as possible. So, Gazeta Wyborcza in Łódź again is organizing its action Catch Your Breasts, prophylaxis of breast cancer. We're talking with experts and we're convincing you to take better care of yourselves. The partners of our action this year are Clariant, Axalta, Świat Zdrowia clinics, and honorary patronate is by Hanna Zanowska. Representatives of the companies that we mentioned here are here with us, and I would like to thank you for being here, for choosing to be with us today in order to talk about prevention and care of our own health. We now kind of invite you to follow what we are talking about here. Our whole meeting today is being interpreted into English. Also, there is a questionnaire, a tool where you can post your questions to our experts. I will then read them out loud to our experts, and I hope we will get their best answers. My name is Agnieszka Urazińska. I'm a journalist for Gazeta Wyborcza, and another time, I have this pleasure to host this meeting because I am convinced that it is not enough to close your eyes and pretend the illnesses are not there. It's better to know your enemy in order to fight it in an effective way. Today, we have the two experts here with us, Eva Klimczak, an obstetrician who works also in social clinic, which is called Świat Zdrowia, certified lactation consultant. She has her own brand and her own website, and obstetrician on wheels. Welcome. Good morning, everyone. There is also Professor Janusz Piekarski from the Oncological Surgery Clinic from the University of Łódź. He is also a Deputy Rector for Organization and Students Affairs of Medical Schools of the University of Łódź. Welcome, Professor. Ladies and gentlemen, let me start from the fact that while preparing for this meeting, I talked to many women I know, and I asked them if they are self examining themselves, if they know what prevention is. Many of them said yes, but I was particularly interested in those who said no, we don't self examine ourselves. And I was wondering why. They said, because I don't want to know. Because why should I know this? And the most frequent answer was, because I'm afraid. Do you see this fear in women, Professor? Yes, I do. I do see this fear in everyone. This is reaction because each and every person is afraid of discovering something while they undergo diagnostic procedures, examinations. Well, it's not that me, when I go to a doctor and do some checkup, because of my age, I am supposed to undergo these checkups quite frequently. It's not that I run there cheerfully to my doctor's office. I also have to talk to myself and discuss it in a very serious way with my inner self to convince myself and to overcome this fear because I am also afraid what this checkup might reveal. I understand it perfectly. But this process of convincing your inner self is absolutely necessary because the checkups are absolutely useful. Many of us patients actually blame this fear for their lack of checkups, lack of regularity. Well, I think that this fear, this preoccupation that the checkup might reveal some abnormalities, and in consequence, the necessity to undergo further diagnostic procedures or even a surgery, sometimes it can place us in a position of a sick person, a person that has to undergo a medical treatment, this is something really threatening. This is something that we really dread. And I think this is the main reason. I think that most of the reasons that patients give us in their questionnaires, that, for example, like there is a lack of availability of medical checkups, or the COVID, or any other reasons, are just an attempt to rationalize the real reason, actually, to justify the real reason why you don't go to a doctor and why you don't undergo examinations. This is just an excuse. I think that the biggest underlying problem is our own fear, because if a person regularly does a self-examination, then obviously the fear is the main reason that stops us from doing it. I know it. Yes, I'm sorry to interrupt, but this is actually more. It's a fear, but it's not something that we are afraid of something actual. Because as psychiatrists classify it, when we are afraid, then it's something real. But when it's just like a fear of something irrational, something that is not material, actually, in case of regular medical checkups, this is some imaginary problem that we fear. Of course, the sickness, the illness exists. One of the patients, what I tried to tell a moment ago, was that this fear should be directed, should be redirected in a different attitude, saying that if we find something, it's better to find it as early as possible. Well, yes, this is what we tell our patients. Eva, I would like to ask you if you also see this fear. Do you see these scared women who don't undergo checkups? Yes, but most often I meet pregnant women or fresh mothers, so they are quite used to the fact that they undergo examinations frequently, because pregnancy is some kind of like a protected period in a woman's life. I am more preoccupied for women who are already after pregnancy, who have given birth, and who forget about themselves because they are so devoted to being mothers. And lots of time passes, which obviously wakes up this fear and says, okay, for a long time I haven't undergone a checkup. So what if they find something? And the real thing is not to avoid checkups, but to go ahead and be, let's say, brave, because the more we do the checkups, the more we examine ourselves, the better we are, in better position actually we are, because the earlier we discover something, the better chances for a full treatment and full recovery are. Do you hear it often from women? Like, oh my God, when have I undergone the last checkup? Oh, when I was pregnant. Well, that was not long ago, like 10 years. Yeah, unfortunately, I do hear that. Sometimes it even happens that a daughter asks me, like, where can I find you? Because my mother, for a very long time, hasn't done any checkups. She hasn't been to OBGYN. She hasn't checked her breasts. The daughter is 20 plus years old, and she herself is already thinking about it. So the whole myth of a Polish mother who is taking care of everyone else but herself, well, it's still alive, isn't it? Yes, definitely. For Polish women, other people are the most important, and taking care of their own health is somewhere very, very last. Yes, because we feel immortal. Professor, I see you nodding. So it looks like you know this topic as well. Yes, I would just like to confirm exactly the words of Eva, who has just spoken. In women who are diagnosed with breast cancer, my patients, very often I hear from them like, my last visit to OBGYN was when I gave birth, and this woman is like 60. Her last labor was when she was like 32, and this was still not a prevention, it was just a visit because she needed it. And meetings like ours today are here to remind the women that this is not enough to go to a doctor when you're pregnant. We need to go to a doctor regularly. So while speaking to doctors and patients, I very often hear complaints about the healthcare system, about long waiting lines, about how slowly the diagnostics go. Yes, but when you get to the diagnostics, when there are mammograms available, ultrasound checks available, there are programs, preventive programs for 30, 40 plus women or men. Now, we have many of these programs which actually offer some checkups which are absolutely for free. The possibilities are there, and the patients do not want to adhere to these programs. Many doctors say, and I even heard some of them speak about this idea, that maybe there should be some way of inviting the patient, encouraging the patient to maybe use these free programs by changing the insurance system, by maybe giving them some discounts in premiums for regular checkups, like you do with your car. If you drive your car without accidents, then you pay less for your insurance. Do you agree with it, or do you think that there are other reasons for which patients do not want to use these free programs? Professor, let me start from the very beginning. It's not that patients complain about the system and the doctors complain about the patients. I think that doctors complain about the system at least as frequently as the patients do, or maybe they even have more doubts about it. So, yeah, the system is not effective at all. And this inefficiency, I think, comes from the fact that we have a very low number of doctors per thousand inhabitants when it comes to statistics within the European Union. There are some specializations, some doctors which are really lacking, and one of them are the specialists in diagnostic imaging. This is the part of prevention that I think is one of the most crucial. Um, but there is also another aspect of this all, that sometimes we do have these free programs, but there are no patients willing to actually use this opportunity and participate in the programs. So there's a lot to do in all kind of sectors or aspects, starting from the healthcare system and also with the patients themselves. Eva, what do you see? When it comes to the organizational skills of the Polish healthcare system, well, we are simply missing too many doctors, obstetricians, nurses. We all see it in our practice. But again, patients and the programs, I don't agree really, because in our clinic where I work, there is this program, screening program for 40 plus patients, and we are actually doing screening for cervical cancer. And our patients do register over the phone. They just get the invitation over the phone, but also the GPs in our clinic simply tell patients about this prevention program, and it is becoming more and more popular among our patients. We also have this cervical cancer screening program where I assist, and I'm doing also the breast self-examination tutorials within it, because I think that the cervical cancer and breast cancer come closely together, and I think they are really important. So those people who do not want to undergo checkups, we are now talking about women when it comes to prophylaxis and prevention of breast cancer. Maybe women do not know what kind of exams, what kind of diagnostic procedures they can undergo, and how can they use them. I think that
I believe that the awareness is growing among the patients. That's one thing that is sure. Now we are more aware, the women are more aware in our society, and they are more conscious of pregnancy. When they get pregnant, they are ready for those pregnancies and they run them the way they should. Let's be honest, the Polish care standard says that during the first visit, there should be this examination of the mammary glands. So the physician speaks about prevention and about this test. So there is this awareness, And it's cool when we can have all those tests like cytology and mammography for all the women between. Cytology is for the patients between 25 and 50, middle-aged women, but not mammography. And I believe that the women between pregnancy and the moment when they start mammographies are left to fend for themselves. And they don't know fully what they're supposed to do because, of course, there are some recommendations of the Polish Gynecological Society, but they are just recommendations. So, how about a program? How about entering schools so that we could check it all from the start? To have those girls learn the prevention. Professor, I'm laughing because, okay, I really subscribe to your point of view fully. But I remember myself at 30, and I remember that at that time you feel you're absolutely deathless. What prevention? Come on, why talking to me about things like those? No, that's exaggeration. That must be the basic, absolutely fundamental reason. We believe that nothing like that would ever concern us. It is only when we're clashed against hurting joints, when we get up from bed and we short of breath, jogging to the second floor, we realize we're not really that immortal and perhaps we should go for a checkup. But it's very hard to convince 30-year-olds that they should do prevention. That's what we are. Oh, well, if we started in schools earlier, then perhaps that would make some more sense. And as I'm saying, the more you speak about it, the more you talk about it, the more you speak about prevention and about the illness itself, and also about the possibility of fighting that illness, the better. That's why, perhaps, Professor, we just say, well, breast cancer is the world's most frequent cancer, one of the basic reasons for death. Why so? Why such an enemy of the women, and moreover so dangerous and so wicked, cruel? Yes, indeed. Now it is the most frequent malign cancer. It's now ahead of prostate cancers, colonic cancer, and lung cancer. 2.3 million new cases a year. Staggering number. Remember, we treat those patients quite uh, efficiently. The time of survival is quite long. If you put together nearly 2.5 million new cases a year and survival time of 5 to 10 years, when you put those together, you realize that there are tens of millions of women in the world who have gone through breast cancer and they are aware and they're still aware of that illness. That's what we learn from the statistics. Survival rate. Well, the earlier the stadium and the more benign, the less malignant form of this illness. I'm glad you've said it. Yeah, in case of colon cancer, cancers are divided like in Sergio Leone's westerns, Western films, good, bad, and ugly. Here we have those which are aggressive and those who are benign. There are ones that are especially aggressive. So, yes, there are those that have good progression and they have very high survival rate, often exceeding 90%. So, that is an illness that is treatable. Professor, excuse me, I know you're talking about Poland. Sorry, Professor. What 90% survival, what does that mean? It means that after over a decade, we can say that 90% of patients are still alive. So they would rather die of something else, yes? Yes, absolutely so, yes. Some are fully cured, and at the current level of knowledge, we can't say that this patient is certainly cured and that one hasn't been so. Yes, I've heard that from the patients themselves. Sorry, Professor. I've heard from the patient that very often Polish physicians, perhaps they are older physicians, that they find it a problem to say, you're healthy. Patients would love to hear it, that you're clean, but they don't hear it. This is not the problem of the physicians, it's their experience, it's their professional knowledge. We can say with certain probability that most likely that patient is cured. There are also cases of relapse after 20 years. We can't say 5 years, 10 years, 15 years, you're healthy. No, 20 years even is not a healing date. No, there is nothing like that. Sorry, I interrupted when you started talking about Polish statistics. Indeed. Now we have more than 20,000 new cases every year and around 6,800 people dying. Data for 2019, the recent data in the Polish Cancer Register. We always have that register completed with certain delay. That shows that every third patient dies of breast cancer in Poland. And a question remains about the time of survival, whether it's 5, 10, 15. Patients who have died now and who have been recorded in 2019 are quite likely ones who fell down with cancer 5, 10, 15 years ago and lived long in comfort. I see. And we know that that you can live a healthy life. What to do to decrease the risk of falling down with breast cancer, of contracting it. Unlike cervical cancer, this is a very good case. Unlike the colonic cancer, where participation in preventive screening tests can save you, it's very important what I've said. In case of breast cancer, preventive and screening testing does not prevent from contracting cancer. We don't have a mechanism that going for prevention, we avoid this cancer. We can try to reduce the probability of a tumor starting through our lifestyle. Could you please give us some hints? Science breaks down the factors that predispose us to uh, contract colonic cancer into modifiable and non-modifiable factors. Non-modifiable are the ones that we can't influence. The first menses, how long you menstruate, and that's also the number of pregnancies. So these are generally some factors that we cannot impact. We don't make purposeful impact on that. We don't make our life decisions only to reduce the risk of breast cancer. For example, considering whether we want another child or not. Does a pregnancy increase this risk? That's my question. Does the number, which way does the risk go? The more pregnancies, the smaller the risk. That could be, family supporting policy. It's all connected, obviously. Now, modifiable factors, factors that can be modified, are the ones that we do influence, that we can make impact on, taking our daily decisions concerning our life. One of fitness instructors, and I follow her, once said that it all depends on how we treat our lives. I enjoyed that statement very much. Whether we think in long terms, we have one life, one health. Do we use it so that we focus on daily pleasures? Okay, I don't care about tomorrow. That's a carpe diem. We think about our life as a certain good, and if we care for it, it will serve us Well, probably for many, many years. What do I mean? Well, the myth of good alcohol that protects us from cardiac diseases, nobody believes in it. We know that even smallest doses won't help. It's poison that impacts actually all our organs, the brain, also hormones, and that translates also into the risk of contracting breast cancer. We know, and we can be sure that's one of the most interesting things, and I keep on talking about that. If physical activity is what protects us, of course, not 100%, but decreases the risk of breast cancer. Women who are physically active regularly, who care for themselves, they are the women who have lower risk of falling down with that illness. And even if after contracting it, they increase their level of fitness, they have better hope for survival. It's true about two types of cancer, that's colon and breast, where activity impacts greatly and positively our opportunity of survival. At the same time, decreases the risk of uh, contracting this cancer. Also, the body mass, the amount of fat in a woman, that impacts the hormones and some changes that also are responsible for development of breast cancer. So keeping your proper body mass is of key importance here. But that's a whole package, really. That's a package of a certain lifestyle. I cannot imagine a person who is all the time intoxicated, smokes a pack of cigarettes a day, and only eats salads and runs so and so many kilometers a day. I can't believe a person like that. Those behaviors come in a package. Sports activity, taking care of yourself, don't mean just putting cold shoulder to all the alcohols and cigarettes, just reducing those. Now, as a lactation consultant, I can say that long breastfeeding protects from breast cancer, and I will be one who would advocate as long breastfeeding as possible. Right, let's go on. And it's a preventive campaign, so this is preventive. Lifestyle's lifestyle. But just like you said, Professor, you cannot simply avoid it, but you can detect it earlier. The earlier, the better. Let's go on to the studies because to tests. Sorry, you speak of self tests, mammography, and ultrasonography. I know, Professor, that you strongly support self tests, but the first two are important. It's probably best to use them all in a package to complement one with another. What is the difference between those? Could you please help us about that? Well, I'll try to be as brief as possible, but that's a subject for quite a lengthy lecture, 2 hours or even more than that, about the differences in all those tests. Well, I really find it difficult to say it all in one sentence. Okay, you can go on. Each of these tests, each of these methods tests something else and uses different methodologies. One of them will focus on something else. Mammography is X-ray. Ultrasonography is wavelength, sound wavelength, and then palpation. That's testing with your touch, and that is a self-test. It may happen so that you can feel under your fingers the tumor. We run mammography and then we see this cancer. We can't see this cancer in a mammography. Sometimes it is visible in mammography, and then we do ultrasonography, and you don't see it, even though we know that there is this cancer that we found with our hand.
We shall remember that each of these methods bring us different information, so they are not replaceable one with another. They all have their place in our approach, and altogether they are extremely efficient. So it's absolutely recommended to use them all. An ultrasound is safe, but it's not very broadly available. The physical examination is so a self-examination or physical examination by a doctor. It's a very safe method. It is absolutely available to everyone. A mammogram also has some limited availability, let's say, because you need to call, you have to register, have an appointment, or simply answer to an invitation that you get. Out of these three methods that we list here, a mammogram has one very important characteristic. It's an X-ray, so we cannot abuse this method. So we are not saying to our patient that they should do it once every 3 months, because if we examined our patients with X-ray every 2, 3 months, then probably we might have induced more cases of cancer than we actually discover. So a mammogram is an examination that you should undergo in a certain rhythm once every 18 or 24 months, because doing it more often might be harmful or dangerous. An ultrasound can be done over every 6 months, and then self-examination is perfect to be done once a month. Let's not forget that mammography is a method for women over 45. Well, yeah, that's another topic. I agree. I agree. Thank you for this observation. This is a question very often asked by students and patients. What is better, a mammogram or an ultrasound? As I said just a moment ago, these methods use completely two different physical factors. So, an X ray, a mammogram, that's one thing, and an ultrasound, which is a wavelength based examination, is a different thing. And the way in which different tissues can be seen by one and the other method of imaging differs. In an X-ray, the adipose tissue is gray. Usually, the lesions like cancer look like a white star. If a woman is 40, 45, 50, her breasts are made mostly of adipose tissue. So in a mammogram, what we see when a woman has breast cancer, we do see a white star over a gray background, dark gray background. So this is a method that shows very well on the principle of contrast simply breast cancer on the background of adipose tissue. Instead, if we have glandular tissue in a mammogram, this is white as well. So if a woman is 30 years old, we are looking for a white star against a white background. This is why this method is less efficient in younger women. It absolutely confirms what you said, that elderly women or women who have prevalence of adipose tissue in their breasts, this method is definitely more efficient. So it depends also on the type of breasts that a woman has. Um, the same thing about ultrasound. During lactation, for example, we absolutely do not perform mammograms, but we can perform a perfectly safe ultrasound. In this case, we are looking for cancer which looks like a black spot against a white background. So these diagnostic imaging, mm, is it is it like once a year, once every 2 years that we should do it? Yes, it is actually above 50. Depends again on the country, depends on different policies that different countries have. Some of them do not do it anymore, some of them do it more frequently. Usually it's between 18 and 24 months between 45 and 69 years of age, every 18 to 24 months, diagnostic imaging should be done. And an ultrasound is not taken into consideration as a screening method, like a preventive screening method, because so far it's not been yet established that it can actually increase the survival rate. So it is not included in recommendations for screening, preventive screening. Apart from women of very high risk, so women who are, for example, carriers of a mutation in BRCA1 gene, um, the ultrasound is basically the decision of a doctor, of the physician that the patient goes to, or it can be a decision of the patient herself. Usually, there is no point in doing it more often than once a year. Okay, I'm asking this question because I think that these things are worth knowing, but also because I hear it from other women, and I also caught myself on thinking like this, that if the last test, the last checkup is good, the woman leaves the doctor's office and she feels immortal. She feels perfect. She feels like she's never going to die. And until the next appointment in a year, in 2 years, sometimes it turns out to be 3 years or four, even if we do it regularly, every year or every couple of months, this woman feels completely safe. But apparently, there is no reason to feel completely safe because, yeah, I had, for example, this experience that I was doing regular checkups, and patients say that they were doing regular checkups, but the cancer was discovered between the checkups. So this is why self-examination is so important. And I would like to now dedicate some time to self-examination because the awareness, I think it's not high enough among patients. Yesterday, we were talking with Eva before our today's meeting. We were just discussing things, and Eva admitted that women who come to her and they perfectly know how to self-examine their breasts. These are very few patients and I know that an OBGYN doesn't really teach very well the patients how to self-examine breasts. Even in a GP practice, like when you go to your first contact doctor, they usually don't teach you how to do that either. So, Eva, please let me know your perspective. What about our awareness? What about our capacity? Well, I think that we shall actually educate obstetricians, maybe nurses at schools should, for example, do this kind of training and teach girls how to self-examine their breasts. Because the earlier we start, the better it is. Maybe these girls could teach their mothers, their older sisters, because of course the perfect vision, the ideal vision would be that a patient reaches her GP or her OBGYN or her obstetrician, and this person, this health professional, has enough time on their hands to educate her about prevention and can teach her, for example, breast self examination. I see the professor smile, and I know that I'm talking about some ideal world that doesn't exist. The reality is different. And as the professor said, I am 30 and immortal. So I'm still trying to talk to each of my patients and ask her, have you had your breast checked recently? Do you want me to check your breast? Every visit, every time I see my patients, is it if I'm just a regular obstetrician visit or is it a lactation visit? I always offer a breast checkup. It sounds like a fairy tale, what you tell. Yeah, it sounds like a fairy tale, but my home visits last usually like an hour. It takes time simply, but my patients, I think that are taken good care of. They are always updated, examined. I always remind them about self-examination. I have some leaflets that I usually leave to my patients, just saying, please hang it somewhere in your walk-in closet, in your bathroom, or wherever, and just every month go step by step what the instruction tells you in order to perform this self-examination. Eva, you have taken part in a prevention initiative in high schools. Could you tell us what was it about, and do you think it's useful? Do you think it's okay? Yes, I think it's very useful. This program was called A Healthy Student, and was financed by one of the local governments in one of the Polish cities. And together with my colleague, a urological nurse, I was there for the breasts and she was there for testicles. And we were visiting high school classes, teaching students how to self-examine, on my side, breasts, how it's important to self-examine them, how to recognize problems. And she was talking about self-examination of testicles. There was obviously a group of young people who were not interested at all by what we were going there with. But most students were actually quite interested. They listened with attention. I was kind of threatening them, saying that it's the cancer that causes the highest mortality and that it causes the death of a huge group of women, that it's very dangerous, that actually it deprives us of our femininity because breasts are femininity. And many teenagers were kind of scared by what I said, so they were listening carefully and they were following the instructions step by step. We were practicing because I brought some models. I brought a model of a healthy breast with me, for example. I had a model of a breast with a small lump in it, and I had a breast which was very sick. And I showed them that this very sick breast had a very bad prognosis. And the students that I was talking to, were really, really preoccupied. I think that fear and making people afraid was not the best option, but as long as it works, everything is fine. Yeah, it would be good actually if we had at schools some kind of training, some kind of instruction how to self-examine the breasts. But we're not at school anymore. But we have you, fortunately. Oh, let me interrupt again. I would just like to add something. I know that we are passing on to the practical instructions, how to self-examine your breasts. But before we do so, I would like to just say one extremely important thing, why this examination is so extremely important. We are, and I have been trained like this also for years, and I used to teach this to my students. I was taught certain truths that I know that can be actually discarded right now, because it's not true that breast cancers are all the same and that they all develop from a small lump that very slowly grows and starts to be bigger, and this growth becomes faster. And if we catch this neoplasm early, if we don't do anything with it, then it can grow slowly, slowly. No, we already know that this is not true at all. That this is true only when it comes to certain types of cancer. The slow growth, the acquisition of certain characteristics, that it's not very malign at the very beginning, then the malignancy grows with the growth of the lump, uh, that it becomes more and more dangerous with time, and it acquires characteristics of a more malignant type of cancer, we know this is not true. Some cancers do follow this pattern. These are the kinds of cancer that we can discover easily with diagnostic imaging, with ultrasound or a mammogram. But there is another group of cancers. These are kinds of cancer that are very malignant from the very beginning, and they grow very fast from the very beginning. We have no idea when they appear, when they start to be there. One of my patients that I took care of like a year and a half ago, she said that she had had a mammogram in November and there were no lesions, no alterations. About the time of Christmas, she found a lump in a self examination, and this lump was actually growing visibly. She felt it grow right after the examination. It was a very aggressive form of the neoplasm. We cannot um, detect these very quickly developing cancers with diagnostic imaging. We have to be aware that in a mammogram or in an ultrasound,
we can only discover some of those. The remaining breast cancers will remain undetected and they may develop between the successive tests and they will be growing very fast, whether we do image screening, image testing. The only way of catching them early is regular monthly test, and that's why we do it. That's why those self-tests are very important, because the myth that cancers grow slowly, that they grow so that you can do imaging and we will definitely discover them, that's a myth. Some cancers grow very fast. For example, they come 6 months after mammography, and the only way to catch them is your self-test. And that's why it is so important. Professor, thank you very much for these words, Professor. One more question. Does it happen to you that partners of men find those tumors? Very often so. Yes, in sexually active women and in the women who have the courage to say that while meeting a GP. How did you find it? Well, my partner, my husband, found that this is something that wasn't there 2 weeks ago. By all means, it is so. So there are those two stories that I have. One is I was washing, I was taking a shower. The other one, my partner found it. Okay, we can smile a bit, but it's also an important element in prevention. Just like you said, there's knowledge of your own body and comparison. That is important, Professor. The more so and the more eagerly would I ask Eva to say and perhaps to demonstrate how we should do our self-testing. Let's start from the question when to test yourself. It's best to do it between the 7th and the 10th day of the cycle. We say that the first day is the first day of your menses. So between 7th and 10th day, when the breast doesn't hurt you and it's soft, when this glandular tissue won't be felt under your fingers. So this is for those who still have menses. Those who don't, in my practice, I suggest that it is one day a month that you choose. How about your birthday? I was born on the 24th day of a month, and I will be doing that test on 24th. So self-testing on the 24th, the day of my birth. Once we've decided when to do it, let's go on and say how to get ready. It would be very good if we were in a room that we find very comfortable. It's got to be warm because we have to undress from the waist up and we need a mirror because the first stage is just watching your breast. So we undress, we stand opposite a mirror, we let our hands loose along the body loosely, and we watch our breasts, whether there's nothing changing, whether there are no uh, pinches, no readiness. What does the areola look like and the nipple? If it is concave, perhaps if it was concave, whether it's now not convex. So whether everything looks like it's always been. Then we lift our hands, keep them behind our head, and we watch whether perhaps anything has changed with our hands up compared to our hands down. The third one is putting our hands on the hips, and then again, we try to see whether everything is as it used to be. Then we continue to self-exam. I have that model of a breast here that we will use as a visual aid. Now, the most important thing is 3 fingers, and we touch not too strong, but we must feel the structure under our fingers. And now we have 3 methods. First, we can go inner ring from the external edge out, and then we can also do it star-like, so go from the nipple further away. The method is that every centimeter must be tested, and the last in waves, up and down, up and down. You start at the top, each centimeter of the breast, and that's how you are tested. Once we have tested every centimeter, we pinch the nipple to see whether there is nothing leaking from it. There is no abnormal discharge. There are two moments when you have a discharge. First is pregnancy, and the second, of course, is lactation. So when you place your thumb and forefinger and there's nothing flowing out, no discharge, we go on to the next stage. And we now move to the armpit, and you need to put your fingers into the armpit and test every centimeter within the armpit. So that's your breast self exam. Centimeter by centimeter, millimeter by millimeter, you do it with three fingers because the breast is built in say that there is the tail that goes up to your armpit. If you feel anything there, it can be your gland. Mm, in case of anything that makes you anxious, it can be the looks, it can be lumps, something hard under your fingers. You've got to go to your doctor. GP is the best because GPs will send you on. You have plenty of patients who say, yes, I do these tests regularly once a month. Well, I don't run those statistics. I just ask whether they do it, whether they test. Quite a few say that yes, they do. Sometimes they smile, saying, I do the test, my partner does the test, and then they take it easy. There's USG, so ultrasonography and mammography in late age. Well, we hope that after that meeting had we would have more women doing the self-tests. Professor, would you like to add something to it? If I could add something, because I absolutely subscribe to every statement that has been said here about this self-test. I fully agree, but I would add some things if I were allowed. Yes, please. Some extras and wrap up what has been greatly described a moment ago. What you've said a moment ago, that is what we're interested are the changes. If you have inverted nipple for 20 years, that's just your build. Probably you have short milk ducts. And when your breasts were growing or you got a bit fatter, the volume of the breast increased, but the ducts were so short that they held the nipple and they are pushed inward. So that's no reason for concern. We will find the reason for concern is when the nipple was regular and now it's inverted this month and it doesn't stick out. That's a change and that's a reason to worry. No one knows a breast better than the woman who is its owner. If you do this self-test regularly, watching yourself in the mirror, you will say, "Oh, I didn't have that dimpling or puckering." All the changes are extremely important. That's just wrapping it up and paying attention to the things that you've discussed. Now, from the technical side, I'd just add one more thing. Breast test can be difficult for women with large breasts just because the access, especially to the bottom quadrants, what we see below the nipple, is difficult just for the reason of gravity, is limited to gravity. Our technique, as you've just said, is that we try either using the three finger technique or using also three fingers, but the whole uh, area of it, we try to press the breast to the chest, moving the fingers or moving just the long sections of our fingers, whether there's nothing jumping, no lumps jumping between our fingers and the ribs. Standing like this, we can very well test the top quadrants because they are flat and they are stretched. And we just do it in circular movements. We can find that there is nothing or there is something that's leaping between our fingers and the ribs. It's very difficult in the bottom quadrants. Now, the method that's being described a moment ago, the moment of doing it with your hand stretched above and holding the back of your head and then testing your breast with a hand up is a very good method for testing the lower quadrants, especially when the woman is lying. When a patient comes to my study, oncological surgery, and she believes she has cancer, I don't even test her standing. I just say, please lie down. Please lie down and please put your hand behind the back of your head. Why? Because in this way, the breast, which is lying on the breast muscle, is stretched and it's as flat as it only can be. It is the thinnest and the flattest, then testing it point by point, I can test is best. With a large breast, I can use one hand to move it up and to test all the structures below the structures which we have in the lower quadrants. I can also move it to the center of the chest and then test the outer quadrants. I've got to move it so that it's as flat as possible during the test. I'm looking for the structures between my hand and the patient's ribs. So decidedly, I would suggest that you do physical test lying hand on the side of the breast that we are testing has the hand pushed behind your head. That's the easiest way to find it. So that's just, an advocem. You can do it before going to bed. You can lie on your pillow, put your hand behind the back of your head, and then test your breast. Professor, you've already said it, that no test will save you from breast cancer. Yeah, that's not the reason, that's not why, and that's the bad news, of course. But you also have good news for the patients when we talk about the progress of medicine, the potential that medicine now gives us. Because what we're most afraid of is we are aware of being lethal, of being destructible, and we're afraid of being maimed, of that meaning being maimed for life. And you talking about technology, that breast reconstruction technologies, operative technologies favor us, help us. Could you be please a bit optimistic about that? Well, yes, there is fully justified optimism here because the progress that we've seen in oncology, especially in breast cancer and also melanoma, we see that every now and then we changing the principles of treatment, the rules of treatment. Things we used to consider dogmas are now historical methods, really, of treatment. Yes, the progress is unbelievable. It's even dramatical in the positive sense that the scopes of interventions have changed. Breast amputations occur in minority of patients. Most receive saving therapies, and we use surgeries, uh, removing just the tumor. We use radiotherapy and either hormonal pills or chemo as the so-called systemic treatment. The good news is that women treated in that manner, and that's something we already know, have longer life expectancy than those who have undergone breast amputation.
Apart from the fact that they look differently, it's incomparably a less invasive method. Also, the prognosis are definitely better. These women also feel better, don't they? Like physically, because it's absolutely not indifferent how you treat a patient. Oh, yes, I agree. I would say that some of our um, capacity, some of our possibilities of surgery are dying out because we actually are not doing them anymore. These very broad surgical procedures we used to perform almost every day, now we do it very rarely. Sometimes, quite often, a woman after a breast cancer treatment leaves the hospital with just a very small cut in the breast and a very small cut in the armpit. Sometimes it's hard to find the scar where this woman diagnosed with a breast cancer that underwent a surgery, where the cut was actually performed. Eva, would you like to add something? Do you also observe this progress of medicine and this progress of less invasive methods? I think we are having some problem with Eva's connection because she froze. Um, so let's waiting for her while we wait for her to reconnect. I thought this might be a good moment to check if we have some questions from our spectators, from the public, because I have heard some notice that we do have some questions online. Eva, are you here with us back? Yeah, great. Thank you. Welcome again. I have already passed on to asking the questions from our spectators and from our partners who decided to watch our webinar and also to listen to your expertise. Let me read out the first question. I am 46 years old. Every year I undergo a breast ultrasound. When shall I fix an appointment for a mammogram, Professor? About 50 years of age. Again, according to the guidelines in Europe, it's 50. In America, it's 40 years old. So there are absolutely no contraindications to do a mammogram now. But if we talk about a systemic screening system in Poland, it is recommended to perform a mammogram at 50. Um, or if a patient has some family history of breast cancer, if her mother or sister or her father's mother had been diagnosed with breast cancer, then definitely a mammogram can be anticipated. Maybe 46 years can be a good moment. Please tell me, that's my question. Uh, so a woman that would like to undergo this kind of exam, what shall she do? Shall she go to her GP to get a referral, or yes, if she wants a mammogram, she needs to go to a oncological surgeon or to some oncological clinic, general oncology, like in our hospital, for example, and just undergo a physical examination by a doctor. That's the first step, and then get a referral for a mammogram. So an oncological surgeon, do we need a referral for that? Yes, we do. So first you need to go to your GP, then he or she refers to an oncological surgeon. The National Health Fund in Poland has just changed this procedure. Um, an oncologist or an oncological surgeon, um, i- to go to an oncologist, you do not need a referral, so it's okay. One thing that I would like to still make a little reference to, speaking about OBGYNs, that they do not want to do breast checkups. I would like to tell that tell you that this comes from sort of a pattern of care for patients who have breast cancer. In Germany, an OBGYN is also a person who deals with surgery of breast and reproductive organs. In the Netherlands, it will be a breast surgeon, an oncologist. A gynecologist will only take care of reproductive organs. In Poland, I think we are closer to the Dutch model, where an OBGYN does not operate on breasts. They deal with reproductive organs only. Is it good or bad? It's just a question of division of contracts or some formal classification. So with breasts, you usually go to an oncological surgeon and not to an OBGYN. I just want to justify my colleagues gynecologists. This is just not um, part of their everyday practice. We do care for these patients. We see these lumps very often. Gynecologists have much less contact with breast lumps, simply with breast cancer, because this is not their field of action. This is a very important and interesting thing. This also goes down to, for example, like dermatological diagnostics. Like if you have some kind of skin lesion that looks like a melanoma, a dermatologist just diagnoses it, but an oncological surgeon is a person who confirms the diagnosis and who treats it later and who can confirm what kind of lesion it was only when they remove it. So a dermatologist only says, hey, here we have a lesion that is suspicious, and he refers to an oncological surgeon. Okay, but Professor, if we have a need, if we ask our OBGYN to show us how to self-examine ourselves, he should do that, right? Yes, it's definitely an obligation of each and every physician. So, as a woman, let me say, women do not hesitate. Ask for help, ask for instruction. Um, if a gynecologist, when he or she sees a breast that they feel is suspicious, they will refer it directly to a surgeon. They will not take care of it. So let us pass on to another question, and it's the following. Uh, what kind of examinations are advised to women of the age of 30 and above? Definitely self-examination once a month, just a self-examination of their breasts, and that's it. Um, Theoretically, you say that once every 3 years, she should go to a doctor to get some physical examination. No diagnostic imaging is advised here, just a typical screening for breast cancer. The risk of falling with breast cancer in a 30-year-old woman is very low. So, self examination, if the woman feels the need, then an ultrasound. And once every 3 years, a checkup by a doctor. There are some more questions. Let me pass on to the next one. Also, a question to you, Professor. What about the genetical um, conditions? How does it refer to potential breast cancer? Well, it depends on what kind of genetical condition it is. When it's a typical genetical condition, so a mutation in genes that we know, genes that are connected with breast cancer, then of course this is a very serious condition because the risk of falling with breast cancer in women that have a mutation in BRCA1 and 2, that's a risk of about 80%. So it's almost, I don't want to say it's a death sentence, but I will want to name it like this. But the probability that she will have cancer throughout her life is quite high, is very high. This kind of patient should test at least two organs. First of all, the ovaries, and then only in the second row, check up their breasts. In the carriers of the mutation in BRCA1 and 2, we recommend the removal, the prophylactic removal of ovaries mm, after 35 years of age, when they turn 35. And at the same time, we also recommend a very regular every 6 months diagnostic imaging of breast, uh, searching for breast cancer. This is a very detailed scheme that these patients should follow. This is definitely a genetic condition that is very serious. I think that now we are referring also to a much broader group of a family history of breast cancer. Among breast cancer patients, it's about 20-25% of women who have family history of breast cancer, where a mother has had breast cancer or a sister has breast cancer, but genetical test does not reveal this typical mutation. Sometimes we don't know why in a certain family there are several cases of breast cancer. Is it lifestyle? Is it diet? Or is it really a genetical condition that causes it? These are women in which we should perform mammograms earlier, about 40 years of age, for example. These are women who, for example, should undergo ultrasound checks more often in an earlier age, and definitely who should look at their body weight, who should do more physical activity, because we have quite a lot of margin to manipulate the risk, actually. And what about prophylactic mastectomies? When it comes to patients who have genetical conditions in family, one of the most important things are how many cases of breast cancer there are in the family. We're talking about ovarian cancer and breast cancer. We're not talking about cervical cancer. We're not talking about uterine cancer, colon cancer, or lung cancer. We're talking only about the close family members, first and second great relatives. We're talking only about ovarian cancer and breast cancer. It's a very important question. At what age did the member of the family fall with one of these kinds of cancer? Was it early? Was it late? Was it a mother who, for example, had a double-sided breast cancer at the age of 40? Or was it one case, two cases, three cases, four in the family? These are all grades. These all define how big the risk is, actually. Uh, if a woman, a mother, for example, is 70 and has had breast cancer when she was 65, and this is the only case of breast cancer in the family, the risk in the daughter is twice as high as the population, but not 10 times or 15 times as high. So, what about the prophylactic mastectomy? This is a topic that turns and returns. Every time we talk about breast cancer, people mention this very radical surgery, actually. What do you think about it? It is quite popular in the United States. It's very popular in the US. In the US, there is a trend that women who have a small cancer on one side, maybe it's like a 1.5 centimeter lump in one breast, uh, 1 in 4 patients, which is over 20%, they request a double-sided mastectomy with a contemporary reconstruction of the breast. That's the US. In other countries, obviously, it's a question of on request. In Poland, this is not an accepted treatment pattern because, according to Polish law, a doctor cannot remove a healthy organ. And the other breast in this very moment is a healthy breast. We are talking about a patient who has a small cancer in one breast and has the genetical risk. We cannot remove the other healthy breast because we are then threatened with a responsibility, a penal responsibility, and we can go to jail for a year or two. The situation is completely different when we have a confirmed mutation in one of the genes, BRCA1 or BRCA2, where according to Polish law, this patient can undergo a prophylactic removal of ovaries and also a double-sided mastectomy. Uh, absolutely, with no discussion, we convince these patients to get their ovaries removed after the age of 35, because we think this is absolutely reasonable. But we are not so willing to remove the breast, because not necessarily the breasts have to be removed. Plus, there has been research showing that if a woman has their ovaries removed at the age of 35, this reduces the risk of falling with breast cancer. It reduces it almost completely. A breast can be tested. There is a trend that when a woman that has breast cancer and has the genetical mutation in BRCA1 or BRCA2, if she gets cancer, um, we still can perform. We can still perform just a less invasive procedure.
If the patient is to live in fear throughout all the rest of her life, in fear that she will have breast cancer and she does not want to run diagnostic imaging every 6 months and then living in a scare for continued, that you can have amputation of both breasts with similar uh, reconstruction, simultaneous reconstruction. Let me move to the following questions. The question was asked where you can take this test to make sure whether there is this risk of inheriting the BRCA1 mutation and what's the cause. I believe in justified cases, this is refunded by the National Health Fund. So if there is some kind of family, especially in the mother, there has been breast cancer, mother, sister, where there is one factor of inheriting it, you need to go to a genetic um, study, and either in Copernicus Hospital, or some other. If there is no justification, you have never had breast cancer in the nearest family, and there have been no ovaries cancers either, then you will probably have to pay for that, but I have no clue of how much it can cost. I can only tell you that that mutation, unless there have been cases of cancer, breast cancer in the family, the probability is very, very low. Okay, my following question is whether hormonal contraception increases the risk of breast cancer, because you can hear people saying that at times. What's the truth? We don't know it. We actually don't know it. That information is there in most course books, that yes, absolutely, hormonal contraception is a risk factor in breast cancer. Old books, are they old course books or the new ones as well? Old and the new, when the authors just copy the old knowledge. Because you need to remember that a woman must take that contraception for some years, 10, for example, to increase your morbidity. And then she must have that cancer. Then some scientists must get the statistics and examine how those cases were developing in the last 10 years. So the information that we have is the information about contraception 30 years ago. If we realize that contraception, which was implemented in 1960s and in the 1970s, changed, then in a single pill you had more hormones that now in a months-long treatment, we can say that yes, contraception used in the 1960s and the 1970s did increase the risk of breast cancer. Now, it seems that with those very small dosages of hormones, very well suited to our organism probably doesn't have any impact. Thank you very much, Professor. It's really a reason to take it easy. Yes, it's a longer story. Yes, in the old books that was confirmed. Now we have totally different medications, and it seems that there is no impact whatsoever. So once again, thank you very much for this information. It's really a reason to get calmer. Now, Eva, why does long breastfeeding reduce the risk of breast cancer? Because lactation prevents you, the breast works, and when the glands work, the child also sucks. And these are the factors that are just helping. Professor, perhaps you could help me. Perhaps you could say more. I just, as a lactation expert, I say that it protects because a child goes sucking the breast. And then there are all those hormonal progresses developing, and we just don't disturb that. This is a very extensive subject. It's very hard to answer this question in a single sentence, but I'll try to answer like that. Speaking of the risk factors here, I just discussed the non-modifiable factors. When does a woman start her menses? When does she finish menstruating? And you usually get this mental shortcut. The more a woman knows about her monthly cycles, the less the risk of breast cancer. The women who start their menses early and who finish late, who never had children, who throughout their lives had non-stop menses, they have a far higher risk of breast cancer than the women who started her menses late and finished early. If in the meantime they had more than one child born, because you don't have your menses during the pregnancy, if she also breastfed when there were no cycles, because lactation stops menses, among other things, so then you simply have fewer of them. I know it's like magic, like a tale that a knight should not do that, and that a woman should not touch a knight while she's got her menses, but there is something in it that was just realized from very intensive studies. It seems that the hormonal changes in those monthly changes, estrogen peaks and progesterone peaks, the number of those peaks in the life of a woman may be the factor that deregulates the work of the breast glands. The more of those peaks, the greater the risk that you will develop your breast cancer. And lactation, that's really the period when the activity of hormones, this regular stop, the removal of several cycles from the life of a woman decreases that risk. So it seems that the hormonal elements, in a certain way, influence the risk of cancer. Hence, we can hear the voices that hormonal contraception can really protect against breast cancer. And these are some voices that are now being heard. I don't know if what I'm saying is not too complicated. No, wise, important. So let me please add one more thing here because it's very important. I know I'm a man and I'm just trying to be talking. You're an expert. Well, a woman's breast is believed to mature finally at the moment of birth. So really, it's only when a woman has finished her first pregnancy and given birth to a child, there are changes in the glands that make that breast mature. The elements of the glands only receive their final form at the moment. Until the moment of finishing the first pregnancy, some elements of the glands are not fully developed and they are more susceptible to the factors that can cause breast cancer. So, the earlier the first child, the smaller the risk of contracting breast cancer because becoming pregnant, it would be best at the age of 16, 18. Okay, I've got two daughters, so of course it's absolutely in inverted commas, but we can see it, for example, in Romani women in African countries where the first pregnancies are very early, and those women don't often have breast cancer because their breasts develop much earlier, they mature at an earlier age, and they are less susceptible, for example, to hormonal peaks. But we live in a world where we will not just try to give birth to children at an early age to protect ourselves from breast cancer. And as you said, in African countries, breastfeeding lasts long. And then there are those studies which compare the women who often breastfed to those women who breastfed only for a short time or didn't feed at all. Well, now this is no longer said, but breast cancer was called the typical illness of the nuns, of the women who don't give birth to children. Ladies and gentlemen, I find it difficult to butt in and to break this discussion because our time is nearly over. Okay, because we could go on for another 3 hours. We just like explaining these things. It's very good, it's very interesting, and I'd like to thank for those precious pieces of advice. May the largest number of people who are listening to us use those, and maybe the largest numbers of women be saved thanks to our conversations. But something telling me that we will meet again next year. There are plenty of questions. I haven't managed to ask all of them, but I believe that you answered so many questions that it has helped. Thank you very much for that. Let me reiterate, my guests are today Professor Janusz Piekarski and Ms. Ewa Klimczak, a midwife. And I'd like to thank you. I'd like to thank everyone who's been with us. And ladies and gentlemen, to all of us and to all of you, may you stay in the best of health. Thank you very much.